Welcome to Assessing and Treating Trauma in Children and Adolescents. I'm Karen Koch, the Director of Mental Health Education at Eastern AHEC. And this webinar series is part of our Child Mental Health in Primary Care statewide project that is funded through the NCAHEC. Without further ado, it is my pleasure to introduce your two speakers this evening. First, Dr. Alexis French. She's a medical instructor in the Department of Psychiatry and Behavioral Science at Duke University School of Medicine. She received her master's degree and her PhD in clinical psychology from American University in Washington, D.C. She is certified in parent-child interaction therapy and in trauma-informed cognitive behavioral therapy. Joining her this evening is Dr. Nathan Copeland. He's an assistant professor in the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine. He has his bachelor's degree in genetics and psychology from the University of Georgia, a master's in public health from the University of Michigan, and his medical degree from the University of Tennessee. He did his child psychiatry fellowship at UNC Chapel Hill. He is also an attending physician at the Duke Center for Autism and Brain Development. He's the child psychiatrist with the NC PALS program. Thank you both for being here, and I'm going to turn it over to you.
Thank you so much, Karen. So yeah, we're going to be talking about, Dr. Copeland and I are going to be talking about assessing and treating trauma in children and adolescents today. And before I jump into some background information on trauma, I want to just take a moment and think about this clinical vignette. So Valerie is a 7-year-old Latina female who arrives at her pediatrician's office for a well child visit. And during the visit, she appears fidgety and nervous. Her mother expresses concerns about Valerie's non-compliance, irritability, sleep problems, anxiety when separated from her, and low self-esteem. She notes that the pandemic has been difficult for the family due to Valerie's father losing his job, which has put a financial strain on the family. Additionally, she states the family was involved in a motor vehicle collision recently, which resulted in the family's car being totaled and a visit to the emergency department. Valerie's mother reports that everyone is okay, but she just wishes that Valerie would listen to her more and just cheer up. So just as we're going through the slides, just kind of think back to this vignette, and maybe at the end, if we have some Q&A, we can talk more about this, things that you might want to think about related to trauma. So I'm just gonna, one second. Okay, so what is trauma? So it's an experience that causes or threatens harm to one's emotional and or physical well-being. And a traumatic event is exposure to an actual or threatened death, serious injury, or serious sexual violence. So, most of the time we think about directly experiencing a traumatic event, but it also can be witnessing it occurring to others, learning about it occurring to someone that you're really close with, or experiencing kind of repeated exposure to the details of the traumatic event. So thinking about first responders or police officers. And so for kids that are 6 years or younger, the witnessing does not include events witnessed on TV or electronic media. So like if a child watches a scary movie, that would not be a traumatic event. And then also for the kids that are younger, 6 years or younger, learning about it happening to someone like a parent or caregiver is required as part of the diagnostic criteria. So types of traumatic events, I have a whole bunch of things listed here, maltreatment, intimate partner violence, sex trafficking, mass shootings, exposure to a caregiver who's been impaired by substances, so drugs or alcohol. When we think about separation, that could be military family-related stressors, so deployment, parental loss or injury. So the prevalence of trauma, it's pretty common, unfortunately. So 1 in 7 children have experienced child maltreatment. So that's, abuse or neglect. More than 1,000 youth are treated in the ED every day for physical assault injuries. And, when we think about the causes of death for young people, it's homicide is the third leading cause for 10 to 24-year-olds, and suicide is the second leading cause of death for 10 to 14-year-olds. And that is actually the case in North Carolina as well. It's the second leading cause of death for youth ages 10 to 17. And, experiencing a traumatic event does increase one's risk for suicide. SAMHSA reports in one of their recent studies that 8% of people in their entire lifetime experienced sexual assault, 17% have experienced physical assault, and 39% have experienced witnessing violence. And that's just reported, trauma. So those are likely underreports. And then in terms of some other things that are considered traumatic or related to, trauma, approximately 40% of US children are living in poverty or near poverty. And that places them at increased risk for trauma and just having, more stressors in their life. So I'm not sure how many of you all have heard about the adverse childhood experiences and the original study that was done by the CDC and Kaiser Permanente in the mid to late 90s. And they looked at members who had that insurance and then did some physical exam surveys. And so the participants, reported, kind of reflected back on their childhood and noted how many adverse childhood experiences or ACEs they encountered. And then they looked at their physical health status and some of their behaviors related to health. And they found that the greater number of ACEs one has, the more likely one is to have a chronic illness, such as heart disease, cancer, diabetes, lung conditions, substance abuse problems, mental health conditions, incarceration, and employment challenges. In a more recent study, I think from 2018, found that more than 60% of adults have reported experiencing at least one ACE. There are some other studies that have reported even higher numbers, like 80%. And 1 in 6 adults have reported experiencing 4 or more ACEs. And so ACEs are a major source of childhood trauma. And ACEs are also very interconnected with social determinants of health that I'll talk more about later in the presentation. So traumatic stress. So that occurs when one has been exposed to one or more traumatic events and develops certain types of reactions, so mental, emotional, and physical. So according to the DSM, the Diagnostic and Statistical Manual, there are certain clusters of symptoms. There is the re-experiencing the event, so those intrusive thoughts, flashbacks, kind of having physiological reactions when reminded of the event. Then there are the symptoms related to avoidance of stimuli that remind you of the event. So really efforts to avoid memories, thoughts, or feelings about the event, or external reminders such as people, places, situations. The next cluster is negative alterations in cognition and mood. So inability to remember details about the traumatic event, exaggerated kind of negative beliefs or expectations about self, other, and the world, distorted cognitions about the causes and consequences of the traumatic event, persistent negative emotional states, so like fear, horror, anger, guilt, or shame, diminished interest in activities that used to bring them pleasure, feelings of detachment from other people, and just the persistent inability to experience positive emotions. And then the last cluster, which are the symptoms that often people are going to see, are the alterations in arousal and reactivity. So those are like irritability, angry outburst, aggression, reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep problems. And so without treatment, if someone has been exposed to traumatic stress, it is associated with all types of negative outcomes. Poor health outcomes. So, thinking about those long-term health outcomes like increased risk for diabetes or heart disease. They utilize more physical and mental health services. They're more likely to be involved with other systems such as child welfare and criminal justice. And then they, are more likely to have learning problems as a result of those symptoms, lower grades, more expulsions or suspensions, which later can lead to, employment problems. So what happens when one experiences trauma, in the body and brain? So, it involves three parts of the brain. So the first part is the brainstem. That's where the internal alarm kind of activates the fight, flight, or freeze response. And the brainstem is often referred to as the reptilian brain. So it really is just like on autopilot. It, helps maintain our, regular heartbeat and our breathing and our levels of arousal, and also maintains energy levels for other parts of our body. The limbic system is our survival system, and it works with the brain stem to kind of assess situations, determine if there's a threat, based on, the sensory information that we're taking. Also responsible for emotions and relationships. And there are three important parts to the limbic system. The hypothalamus, which is the command center for hormones, the amygdala, which is the emotional switchboard, and the hippocampus, which is where we make our memories. And so when a traumatic event occurs, the stress hormone cortisol is released, and the amygdala kind of goes in overdrive to protect us. So, when that happens after the event has ended and they are triggered, the amygdala may go in overdrive again, and because the child is fearing, danger in a normal situation. And the last part is the cortex, which is the outer layer of the brain, which controls rational thinking and awareness. And so when a traumatic event occurs, there is a disconnect with the cortex with other parts of the brain, which makes it difficult to use those executive functioning skills. So really the limbic system takes over. It's that fight, or freeze response. And one is unable to really, problem solve and use the skills to calm yourself down. So here are some common trauma reactions. And I'm going to walk through some different things you may see at different age groups. So for younger children, you may see difficulties with attachment to caregivers, so difficulties forming one or separating from their caregiver, excessive fear of strangers, trouble eating or sleeping, being really fussy, and maybe some regression. So maybe they've reached a developmental milestone but have regressed back with like sleeping by themselves or toilet training. For school age children, they may engage in more aggressive behaviors, become more withdrawn, kind of become very fixated on their safety and the safety of others. You may also notice reenactment of the trauma through play, and it may seem repetitive play as well. They may have nightmares and also difficulty concentrating in school. And then adolescents, it looks a little bit different. They may seem more anxious or depressed. They may engage in some more risk-taking or self-destructive behavior. So, drug, alcohol use, sexual activity, self-harm. And they may display or, endorse feelings of intense guilt, anger, and shame, and really have a negative view potentially about themselves, the world, other people. So for, the PTSD criteria, before I jump into the prevalence of it, you have to have an exposure to a traumatic event, and then one or more intrusive symptoms, one or more avoidance symptoms, two or more negative alterations in cognitions and mood, and two or more arousal and reactivity symptoms. And then those symptoms have to be present for at least 1 month and have to cause clinically significant impairment in, several areas of one's life. So you can see that the prevalence estimates of just trauma, there's a pretty wide range, again, depending on the study, and these are likely underreports here. It is probably higher. And then you see not everyone goes on to develop PTSD, only a subset of kids do. And so what are some factors associated with whether or not someone develops PTSD? So we think about the severity of the event. So how serious was it? Did, someone die? Was someone really badly hurt? How close were they to the person that, experienced the harm? And then proximity to the event. Were they there, present when it happened? Did they learn about it? Did they see it on TV? Caregivers' reactions. So were they supportive? Did they believe the child when they disclosed what they experienced? And how were they handling their own reactions to what happened? And then do they have a prior history of trauma? So we know that children that are continually exposed to traumatic events are more likely to develop, PTSD. And I'll do the last one. So family and community factors. So just thinking about culture, race, ethnicity, families, communities, all those things can be protective factors. And, kind of one's own cultural identity also is a protective factor. But experiences of racism and discrimination can also increase a child's risk for traumatic stress symptoms. I should say that in terms of PTSD, it can occur anytime after the first year of life, which I think is probably to some people that it could happen to, really young children. And symptoms do usually typically develop within the first 3 months of the traumatic event, if they're, if they do experience symptoms, but there could be a delay of months and years depending on how the child was processing what happened. So it may not be apparent right away. So in terms of protective factors to promote resiliency to childhood trauma, support from family and friends, a sense of safety, self-efficacy, high self-esteem, having goals, dreams for one's life, having some particular skill or talent, and having coping skills. So trauma-informed care. So it's really a strengths-based perspective that emphasizes resiliency, and it both the organizational kind of practices and clinical practices. And SAMHSA has come up with the Substance Abuse and Mental Health Services Administration with the 4 R's. So the first one is kind of realize the widespread nature of childhood trauma and how it impacts a child's emotional, social, behavioral, cognitive, brain, and physical development, as well as their mental health. And so not only being aware of for the child, but also the family, first responders, even the staff that work at your clinic who may be experiencing secondary traumatic stress. Recognize the symptoms of trauma. So those trauma reactions that I just kind of reviewed with you all, and the trauma symptoms, being kind of aware of those things, and understanding that some of those reactions, are adaptive, right? In terms of trying to protect themselves from what they just experienced. Respond by making necessary adjustments. So, whatever the child needs to feel safe, feel like they can open up and talk about things. And also just thinking about the policies and practices within your organization. And then lastly, kind of resist re-traumatizing patients and their families. So just thinking about the triggers, and that could be sights, smells, sounds, things that in the office that could be triggering for them. And also, like when we talk about screening, being mindful if you're having them kind of give the narrative over and over again, that could be re-traumatizing. So the elements of trauma-informed care have a number of things listed here. I'm going to just go over a few of them. So when we think about the organizational level, creating a safe environment, not only for patients, but also for staff. So preventing secondary traumatic stress in staff, you can do that through training, having, mental health days or activities available to staff, and then also hiring trauma-informed workforce. And then at the clinical level, it's really, involving the patients in their treatment process, screening for trauma, and training staff in trauma-specific treatment approaches, and then engaging referral sources and partnering organizations. So when I was talking about the safe environment, just being mindful of like the physical environment. So like who is allowed to come in and out of your building? Is there someone at the front desk? Are there signs for how to exit the building, or the exam room easily? Making sure that the noise level is appropriate for the waiting room, keeping parking lots, common areas well lit. So just looking at the time, I'm making sure I'm not going to go over. Let's jump into the screening. And if anyone has any questions about this, I can definitely dive more into it at the end. So why is screening important? So as we kind of talked about, trauma is very prevalent. When we think about just children who have experienced at least one ACE, about 30 to 45%. There is no blood test to test for trauma. There could be some physical symptoms like elevated blood pressure or abnormalities with hearing or vision or growth, physical examination where you see bruises, right? But those are just clues that something else might be going on. So the American Academy of Pediatrics has really urged, different leaders to really identify and address trauma. And PCPs are in a really great position, given how often they see kids and parents, to be able to help identify trauma, which is the first step, and then help get the family connected to the appropriate resources if needed. So trauma experts have suggested that this one question can really be beneficial with helping with diagnostic accuracy and the appropriateness of care. So since the last time I saw you, has anything really scary or upsetting happened to you or your family? And so if we think about more of a prevention, right, and all the things I just kind of told you about, like how to address, this, can help reduce mortality and morbidity. So, that would be the ideal, is you just ask at least that question. I know time is sometimes difficult to come by because you have a million things to do. If you had more time to do a validated screening tool, I've listed some here that are validated measures that are available on the National Child Traumatic Stress Network website or the International Society for Traumatic Stress Studies. And these are valid, reliable instruments. They don't take too long. You see, none of these are too long. I know the last one's a little bit longer. And just being mindful also when you're administering these, if you use one, that you want to make sure that it's culturally appropriate and that it's been translated or validated in that population. And it was developed by Intermountain Healthcare. You can see there's the 2 questions about if you've been exposed to trauma, and then 12 items about trauma symptoms. And I'm going to go more into the care process model. So depending on what the child scores on this, there's a protocol for primary care physicians for what to do next. So this won't tell you if the child necessarily meets criteria for PTSD though. So the child trauma screen is another one for kids 6 to 17. And it can be administered as an interview or a self-report. And there is both child and caregiver reports available. And there are 6 reaction PTSD symptoms that are summed to create a reaction score. So the cutoff of a 6 or greater indicates a high likelihood of PTSD diagnosis. And that would indicate that you should make recommendations for therapy, trauma-focused assessment, or treatment. So this is the Child PTSD Symptom Scale for the DSM-V, the CPSS. So for this one, there is both an interview version and a self-report version. And it is used to measure post-traumatic stress disorder and the severity of symptoms in the past month. And so here at the beginning, it kind of goes through all the different traumatic events that one could experience. It does take about 30 minutes to administer if you do the interview, but 10 minutes if the patient was to complete it. And there's a total severity score that ranges from 0 to 80. And let me just go to the next screen so you can see some of the items here. And it also talks about how it's interfered with one's life. So minimal would be 0 to 10, mild 11 to 20, moderate's 21 to 40, severe would be 41 to 60, and then anything 61 and above would be very severe. And this is the child and adolescent trauma screen, the CATS. And so this is based on the DSM-V, and it's a measure of potentially traumatic events and stress symptoms. And it can be administered as a self-report or an interview. You can see there is one for very young children. There are also one for 7 to 17-year-olds. And it has 15 items that measure the traumatic events, as you see here. And then 20 items that measure the symptoms. And it is available in several different languages. Let's see. And they have cutoff scores to kind of indicate if it's likely that the child meets PTSD criteria. There is another one that the AAP has recommended. I did not list here because it's not child specific. It's called the Primary Care PTSD Screen for DSM, the PTSD-5, developed by Prince and colleagues. And it's available through the VA, the National Center for PTSD. It only has 5 items, but again, it's not specific to kids, so you may not catch, the screener may not catch some of the symptoms that kids experience versus adults, but it is available if people are interested in checking out, because it is pretty short. Okay, so I know I mentioned earlier that, how social determinants of health are related to ACEs. So, there are 5 domains that we think about. And so for economic stability, so that would be employment, income, expenses, debt, medical bills, support. When we think about neighborhoods and environments, housing, transportation, safety, parks, playgrounds, walkability, are there sidewalks, where you live, your zip. Then for education, literacy, language, early childhood services, vocational training, higher education, food, so hunger, access to healthy options, community and social context. So are there supports in this, in the community? Is there discrimination, stress, social integration, and then healthcare system? So healthcare coverage, provider availability, which I know is a huge issue right now, quality of care. So just thinking about those things and how they are associated with ACEs and trauma. And, those types of things can affect someone's, physical and mental health. So just thinking about that as another thing that you may want to screen for. And North Carolina, the state does have a screening tool, and but this would be also helpful to maybe use when you are asking about trauma as well. So you get a positive screen, and I should step back and just, when we talk about screening and why we would want PCPs to do that, right? There are a shortage of child and adolescent psychiatrists, as you all know. There are a shortage of therapists out there. And so not every kid is going to be able to get connected to one of those providers. And knowing how prevalent trauma is and social determinants of health, I think it's, important to try to do this if you have the time, because, when we think about prevention, it's a way to reach kids that maybe would not get reached and have encountered these things and get connected to resources. So according to the care process model, these are the steps that you take based on what you get on that, the Pediatric Traumatic Stress Screening Tool, the PTSS. So on that, if someone endorses that they're abusing, their parents are abusing them, or someone has abused them, or there's neglect, then you may need to make a report to CPS, or there's intimate partner violence. If the child endorses, suicide, then you would need to respond to that. And so you can do the Columbia Suicide Severity Rating Scale to determine if the risk of the suicidal thoughts, and then do a safety plan if that's appropriate. Or you may need to have the child go to the emergency department. And then depending on the score, they have a stratified treatment approach. So if the score is 10 or less, it would be protective. And so that would involve kind of a strength-based approach, like guidance, continued monitoring. 11 to 20 is the resilient promoting approach. So providing referrals to the community for more thorough assessment and treatment, as well as teaching a skill in the office, a brief intervention to target one of the symptoms. And then if the score is 21 or greater, it would be a restorative approach, including referral to evidence-based trauma assessment and treatment, as well as teaching a skill to target the most disruptive symptoms. So in terms of the brief interventions that primary care physicians could do, so thinking about providing psychoeducation, belly breathing or relaxation techniques, guided imagery, progressive muscle relaxation, behavioral activation, parent-child communication, right? So those could address some of the sleep problems, the hypervigilance or the intrusive symptoms, the avoidance or the negative mood symptoms. And one other thing I would note, there are people, whether or not you should screen everyone that comes into your office, only a subset, there are pros and cons of doing both. I think if you screen everyone, then you're not being biased about who you're screening. And that way it's just part of your practice that you're doing for every single patient. I think the downside of that is some people feel like, well, if I don't have rapport with this family or this child, then they may not feel like they can talk to me about this yet. They don't feel comfortable enough. And so I don't want to re-traumatize them. But, so I think there are pros and cons, but there are a lot of advocates of doing universal trauma screening. So trauma is, as I've already mentioned, underdiagnosed or misdiagnosed. There's often a lack of awareness. There are symptoms that kind of overlap with other diagnoses, and then patients with families about trauma. And then, there are no, Dr. Copeland's going to talk here shortly about medications for symptoms, but there is no FDA approved medication for trauma specifically. So I'm just going to go through some of the evidence-based treatments. So this is trauma-focused cognitive behavioral therapy. And so this is for kids 3 to 21. Sorry, that keeps doing that. It's 12 to 25 sessions. It can take longer depending on, how quickly you get through. So there's 2 parts, and the exposure is throughout all of it, is teaching the child skills. So there's psychoeducation, relaxation, affect regulation, and then the cognitive skills. And then the second part is writing a narrative about what happened and kind of going back to see where there may be some distorted thoughts. And it's also a way to kind of habituate to what, if there are trauma triggers, talking about it, it desensitizes them. It has the strongest research evidence of any treatment model. And it addresses, a lot of those trauma symptoms, as well as, teaches them, coping skills that they can use in the future as well. And the idea is that it's really going to strengthen the parent-child relationship, because maybe the parent didn't respond appropriately, or the child didn't want to talk to the parent about it. So the parent is actively involved in this treatment. So attachment biobehavioral catch-up. So that is for very, very young children. I do think they have one now that's for a little bit older, but the original model is for, kids from birth to 48 months. It's a manualized treatment, so it is 10 sessions, no more, no less. And the provider is in the home, helping the parents learn how to provide nurturing care, be more sensitive and responsive, and kind of reduce frightening behaviors. They do not work on the parents' own trauma. If they have that, it's really focusing on the dyad. And there have been a number of research studies that have shown that, it does improve attachment. So children who have had insecure attachment move to secure attachment. It changes the cortisol pattern. It changes longer term outcomes, behavioral regulation. So they're actually right now following some of these kids as they get older that participated in this treatment. So this is another one for younger children, child-parent psychotherapy. As you can see, it is a lot of sessions, so that's the downside to it. It is focused really on domestic violence, but it really, focuses on safety, helping the child regulate their emotions better, and improving that child-caregiver relationship. And it has been shown to be effective at reducing the child's behavior problems and improving the parent-child relationship. And it also does take into account one's culture and cultural beliefs, intergenerational transmission of trauma, so what the parent has experienced. So it's different than the ABC, which does not address that. PCIT is used for other types, not just trauma. I mean, it's used for ODD and ADHD and anxiety, but it has been shown to be effective at treating children with behavioral problems related to trauma. It's 14 to 25 sessions. It can be up to 6 months, depending on how long it takes the family to master the skills. There are 2 phases where it's really teaching the positive parenting and how to strengthen the relationship. And then the second phase is learning how to implement or give direct commands, and then how to appropriately implement timeout. And it has, a lot of evidence to show that it's effective at reducing these behavioral problems and improving the parent-child relationship. So the alternatives for families in a cognitive behavioral therapy, this is specific to physical abuse, and it really involves the child, the family. And so there are, components of it where you're just meeting with the child and then meeting just with the parent and then with them together. And the goal is to really reduce the use of physical discipline and force and reduce conflict, which is in return going to reduce child's externalizing behavioral problems. Sparks, this is usually done in the school setting or some kind of group setting. It is for adolescents, and it really focuses on the here and now, in the moment, enhancing self-efficacy, connecting with others and having supports. And yeah, it's not an exposure-based model. It's really trying to focus on the here and now rather than kind of revisiting things from the past. But it has been shown to be effective at reducing PTSD symptoms. And then this one, the last one, the CFTSI, it's very brief. And this one is different in the patient and some of the other things that the family may be experiencing related to the trauma, like basic needs being met, and knowing that those things need to be addressed as well as the PTSD. Okay, and so here is where the website at the bottom. So a lot of these things, providers have to be rostered or certified, go through some formal training. So you can actually go and search by county, insurance, and language to find people that are offering these types of services. So in terms of the differential diagnosis, as you can see, I've highlighted in bold the types of symptoms that also overlap with PTSD. So just being mindful that, you know, if a child is seeming irritable, it could be ODD or disruptive mood dysregulation, but it also could be PTSD. So if you haven't asked that question, if something, you know, scary has happened, that, you know, there could be other explanations for it. Okay.
And thank you so much, Dr. French. Really appreciate that. Talking about trauma, how it looks, what evidence-based therapeutic modalities can be utilized for kids that have experienced trauma. And I wanted to talk a little bit about comorbidities as well, for kids that have experienced trauma, for kids with PTSD, the mental health comorbidities that we might see along with that. And one of the reasons for that is because some of these comorbidities can actually look like the PTSD itself, as Dr. French was already pointing out. So those with PTSD are 80% more likely than those without PTSD to meet diagnostic criteria for at least another condition. And those with histories of anxiety and mood disorders more likely to develop PTSD after a traumatic event. So you can see how mental health, right, mental illness can be tied quickly to PTSD and kind of both a back and forth relationship. And Dr. French, you can go to the next slide. And so this slide shows of kids that had experienced multiple traumas, right? Effective increasing trauma exposures on rates of psychiatric diagnoses. And Dr. French had mentioned this earlier in her presentation. What do you see as you start getting to more than 4 traumas that a kid has experienced, even without thinking about a formal diagnosis of PTSD? Your rate of the kid experiencing any psychiatric condition, any psychiatric illness, is approaching 60 to 70%, right? Just that exposure to trauma. And you can see as basically across the board, the more traumas, the more likely a kid is to experience or exhibit one of these psychiatric conditions. You can go to the next slide. And one thing that we see here, right, to kind of just really get into that a little bit more, you know, the previous slide showed some anxiety, some depression, some other challenges. In this slide, and looking at individuals who have experienced trauma or no trauma, so looking at the first columns on the left-hand side, you can see that of any psychiatric condition, those that have experienced no trauma, just 25%, right, in this population had a psychiatric condition. We usually expect like 1 in 5 kids in general to have a mental health condition at some point, and 40% who've experienced any trauma. So that number jumps up significantly. When you head over to subclinical PTSD of these kids that have experienced trauma, right? Think about subclinical. The rate of any disorders we already talked about increasing to nearly 60%. You can see as you go down on those right-hand columns, depressive disorders increasing significantly, anxiety increasing significantly, substance use disorders, disruptive behaviors, all increasing significantly as well. So there can certainly be an element of a kid with a mental health concern is more likely to experience to go on to develop PTSD, but the exposure to trauma, the experience of PTSD can also significantly increase someone's experience for a mental illness or a mental health condition. And you can go to the next slide. In general, as Dr. French had already said, this is from the American Academy of Child and Adolescent Psychiatry practice parameters for the assessment and treatment of children and adolescents with post-traumatic stress disorder. SSRIs can be considered for the treatment of children and adolescents with PTSD. In general, SSRIs for PTSD symptoms do not appear to have much benefit for PTSD in kids. It's a little bit different for adults, and maybe there's a pathophysiology process of development of PTSD symptoms in childhood that might be different for adults, where SSRIs can be a little bit more beneficial for adults experiencing PTSD. But in general, just having PTSD doesn't necessarily mean you should start an SSRI. You can go to the next slide. And so what can we do, right? How can we assess things? I'm sure you're all thinking, we're just giving you screening forms today, right? And that's part of the objective, right? Which is, and I use screening forms frequently in my practice to assess for depression, anxiety, and other conditions, because it takes symptoms and it quantifies them and allows you to track how that kid does over time. So here we have the short mood and feelings questionnaire. And the short mood and feelings questionnaire is a depression scale that's validated, hope I don't get my numbers wrong, between 6 to 17 years of age. So it's the scale that we frequently use in younger age children. And you can go to the next slide. And this is the PHQ-9 modified for adolescents. So this is, many of you have heard of the PHQ-9, a depression scale typically validated for the ages 12 and up, right? The PHQ-9. I've seen some reports that say 11, but I frequently say 12 and up. And one thing that I really want to point out here, if you look at number 1, right? This PHQ-9 has been modified for adolescents. What did they do to modify it for adolescents? So look at number 1, and this goes to one of Dr. French's points earlier, feeling down, depressed, irritable, or hopeless. The irritable is part of the modification for adolescents, right? And this is why when you're working with young kids who might have PTSD, doing a short mood and feelings questionnaire, if they are irritable, getting a PHQ-9 for older adolescents, right? Because that irritability can be a presentation of major depressive disorder in these kids. Go to the next slide, please. And this is the SCARE. This is the screen for child anxiety related disorders. This is a 41 question assessment to assess anxiety in a kid, right? And it is validated 7 to 17, if I remember correctly. Dr. French might be able to correct me on that. But young kids, right, up to adolescents, to identify anxiety symptoms. How else can anxiety present in the primary care setting, or can anxiety present in the community? Just like I was talking about for major depressive disorder, irritability. Irritability is very frequently something that we see pop up in kids that have anxiety disorders, right? It's very frequently what brings kids to a primary care clinic or to a mental health clinic. So just being mindful when we're seeing kids, right, that are experiencing these PTSD symptoms, are there other reasons that we're seeing these core symptoms, right? And can we assess for them using screening forms? You can go to the next slide. Thank you, Dr. French. Now, here's the Vanderbilt. The Vanderbilt also screens for a number of different things. It's validated age 6 to 12. In particular, what I love about the Vanderbilt is the first 18 questions of the Vanderbilt are pretty much literally word for word the diagnosis of ADHD, right? The first 9 questions are inattentive symptoms. The next 9 questions are hyperactive symptoms. I will very frequently just go through the first 18 questions with people when I'm thinking about ADHD. Now, ADHD, while a neurodevelopmental condition, right, and maybe not something that you say PTSD caused ADHD, right? Maybe kids that had ADHD more likely to experience PTSD. The other thing that I would put out is parents that have ADHD maybe more likely to be impulsive, right? Maybe more likely to do things that might be traumatic for the kid, right? And so you can think about that in two different ways. One, is this parent getting help for this impulsivity? Can you assess for ADHD in the parent, even though you're working with the kid? And for the kid, being really mindful that they might be coming from a genetically loaded home that makes it more likely for them to have ADHD. Because ADHD, you can also see irritability, you can see impulsivity, you can see these other challenges that we frequently put under the umbrella of PTSD. So being able to have an assessment for that from the caregiver, from the teacher, can be very helpful. The Vanderbilt also goes through other things like oppositional behaviors, conduct behaviors, anxiety, depression, school performance, things like that. So can be a very helpful general screening tool. Next slide, please. And this screening tool, as I alluded to earlier in looking at that graph, likelihood of substance use disorders among those that experience no trauma compared to those experience trauma, much increased rate of substance use disorders among adolescents that have experienced trauma, children and adolescents that have experienced trauma. Same is true for adults, right? So this school screening to brief intervention is a very short tool that can be very helpful in your clinic when you're assessing children and adolescents for substance use, and has a nice little S2VI algorithm, right? No substance use, once or twice, monthly use, weekly use, for thinking about, does this child need to be engaged in treatment in one way or the other? What I like about and I believe this is my last screening scale, if I remember correctly, in putting this one last, is individuals that are depressed are more likely to use substances. Individuals that are anxious, more likely to use substances. Individuals with ADHD, more likely to use substances. So even if you get this screen and someone has increased substance use, consider these other diagnoses as well. And you can go to the next slide, please, Dr. French. And why, right? Why screen? And this is going to be kind of a quick slide, and we can talk about things in another way too. But why screen for mental health conditions? Well, one, it guides therapies, right? It helps the therapists know what might you want to focus on. And then two, it guides medication treatment, right? So while there are not FDA-approved medications for PTSD in children and adolescents, the data does not really support, for PTSD, the data does not really support use of SSRIs for the treatment of PTSD. There are FDA-approved medications for these other comorbidities that have significant elevation in those that have experienced trauma, right? So by treating these other comorbidities, we can really help these other kids. And what we have here are FDA-approved medications for children and adolescents: escitalopram, fluvoxamine, sertraline. Fluoxetine should be on here too. Apologize that it's not on there. And SNRIs, duloxetine for generalized anxiety disorder. We don't use clomipramine as much, but it is FDA approved in children and adolescents. Fluoxetine has FDA approval for depression and anxiety. Escitalopram has FDA approval for depression. Fluvoxamine and sertraline, when we say anxiety, we usually encompass OCD there. So those are typically the medications that we use. The next slide. Oh, there we go. And then the last one to just consider for primary care providers that might be out there are individuals that work with kids that have trauma. Nightmares can very frequently be a very distressing thing for people that have experienced trauma or have experienced PTSD, right? And while this medication, prazosin, I go back and forth in how I say it, you could catch me on a different day and I pronounce it differently, can be effective for the management of nightmares and sleep disturbances in those that have PTSD. You usually start with about 1 milligram, and you can increase by about 1 milligram every week or a couple weeks or so. If you have up to date, I'd recommend looking at that. But I've worked with a number of kids and adults that just by treating their nightmares, so much gets better, right? They don't fear going to sleep at night. They can sleep through the night, and they just feel more rested in the morning, and a lot of things can get better from there. Dr. Finch, next slide, please. Thank you so much. And as we have already talked about, as we're kind of wrapping up here, In thinking about social determinants of health, social drivers of health, when you think about whether it's Maslow's hierarchy or disaster mental health, disaster psychiatry, right? What is the first thing that a kid and a person needs in a crisis, in disasters? That's to have basic needs met, right? Food, shelter, safety, right? These things are just so important. For those that use NC Care 360, that's great. This is the state resource. There's already been talked about a little bit earlier, that helps patients, helps people connect to resources to address social determinant needs. So this is something, I know it's relatively new, probably past few years or so, and it's still rolling out, but I think it's such a cool program and has such potential in areas of growth. And then also just think about, what resources might be available in your own community when you notice social driver needs. All right, next slide. And this is our last slide well, I think there might be one more slide. There might be a question and answer slide after this. In talking about the North Carolina Psychiatry Access Line, I'm a child psychiatrist that works on the North Carolina Psychiatry Access Line. And it is a phone line for providers who have questions about the mental health needs of the kids that they are seeing, or perinatal moms. So, moms that might become pregnant, are pregnant, or are postpartum, if they have mental health needs, and you're wondering, gosh, I don't know, what might be the best medication to start here? What might be the best therapy or resource to provide this individual? You're welcome to give this phone line a call. Number is 919-681-2909. I'm a child psychiatrist that's on the line, in addition to a couple other child psychiatrists, and we have a number of social workers. Dr. French occasionally is on the line too. That can help provide kind of resource direction and navigation, and happy to help you all in any way and the needs that you're seeing of your population. Thank you all. I know we went just a few minutes over, but happy to address any questions.
Thank you, Dr. Copeland and Dr. French. Let's see if we have any questions from the audience. There is a question. Is trauma the same thing as PTSD?
I'll let Dr. French take that.
I think that those terms are used interchangeably, but I perceive trauma, right, as that traumatic event, having some of those reactions, and whether or not you meet diagnostic criteria according to the DSM-V for PTSD. You may not. You may have subthreshold symptoms. Doesn't mean that you didn't experience trauma, right? And then sometimes you might hear traumatic stress, complex trauma. There are all these terms, and I know it is very confusing, but I do think they are used interchangeably. So, Dr. Copeland, I don't know if there's anything you'd like to add to that.
No. Well, and I think it's a very fair question. One of the things that I think is honestly remarkable about people and remarkable about humans is the extent of resiliency that so many people have. Even young kids have very extensive resiliency in many different ways. And Dr. French had presented a slide that while many people, right, have experienced adverse childhood experience, maybe 50%, maybe even more, the number that actually meet diagnostic criteria for PTSD is much less, right? And PTSD, when we think about the diagnosis of PTSD and why I think the diagnosis of PTSD is helpful, is because individuals with PTSD have much worse outcomes than individuals that have experienced trauma that don't meet diagnostic criteria for PTSD. So many people can experience trauma and look back on it and say, that was not good. That was an unpleasant life experience, and still be very functional and very happy in the world and not meet diagnostic criteria for PTSD, versus someone that does can have substantial challenges in navigating the world and have significant impairment. I think that's why it's so important, as Dr. French was pointing out, those PTSD screening questionnaires, which is individuals that screen positive for PTSD really probably need an intensive therapy. and really need to be engaged in kind of different resources. Whereas those that have experienced trauma and don't have PTSD, we keep checking on them. You know, we're like, are you okay? Are you doing okay? And how can we support you in a different way? But I think it's a way to gauge what resources that someone needs. And I agree, they can sometimes be, we talk about trauma, we talk about PTSD, we talk about all these other complex things, but they are a little bit different, and different people develop PTSD who might experience the exact same trauma. So it's an interesting thing to think about.
Yeah, treatment, if someone comes into your office and just experienced that traumatic event, maybe they haven't started to develop those symptoms yet that meet the threshold for PTSD. And so if you get them connected to supports, maybe not necessarily intensive treatment, that could help, ward off the development of that disorder.
We do have two other questions. The first one is, how do you overcome parents' or grandparents' reservations about attending therapy to help children with trauma-related issues?
Yeah, that is a really great question. And I think it's really tough, right? Because a lot of times parents have their own trauma histories potentially, or maybe the trauma has, was the traumatic event is related to someone in the family, if we think about abuse. And so I think getting the parents' buy-in or caregivers' buy-in is really, really tough. I think the more psycho-ed you can do and having that empathy, compassion, trying to help them really understand how maybe their way of interacting with the child or their own, history may be affecting the child. And by, I guess, also thinking about, if they do get treatment and the parent is able to engage, how that's really going to improve the outcomes for that child. And a lot of those behavior problems or school problems, those things are going to improve. I think you may have to just, be very patient and take it very slow to try to get their buy-in and meet them where they're at. So I don't know, Dr. Copeland, if you have any additional thoughts about that.
And I think that's fair to just think about, meeting people where they are, and the parents and grandparents, are bringing in their own traumas, into the meeting as well, right? And I think that's a challenge too. Who's the identified patient, but being sure that families can feel supported in going through this stuff. But I hear it that getting people to attend can be a challenge.
We do have two other questions. The first one is, I really struggled after Hurricane flood. 1/3 of our county was underwater, and she struggled with helping families. They lost everything. What can we do in a moment when someone presents to our office after a large event like this, when everyone has experienced trauma?
What I would say in regards to that is, I mentioned disaster mental health earlier. That a lot of times it's preparing for kind of these disasters, and it seems impossible to prepare for these type of disasters. But Google search disaster mental health. The Red Cross has great resources on that. There is a .gov website in looking at disaster mental health. As I maybe said earlier, in thinking about even isolated traumas, one, people that experience that trauma, not everyone's going to go on to develop PTSD. So some people might be more at risk, right? Those that already have mental health concerns, those that have already experienced trauma in the past. In case of a disaster, I do continue to believe that the most useful thing that we can do is be sure people have their basic needs back. I think, and that includes food, that includes shelter, that includes these other things. So, really working hard if people are struggling to ensure that those basic needs and safety needs are met for those individuals.
I totally agree, Dr. Copeland. The other thing I would add is just that whole analogy, of needing to put on the mask. If the plane is going down, that you need to put your mask on first before you can help other people. So making sure that you're taking care of yourself, your own mental health, and not overextending yourself. That you're not going to be that helpful to other people if you're not taking care of yourself. So just keeping that in mind.
And then we have another question. How do foster children receive therapy for trauma/PTSD?
So they can participate in any of those evidence-based treatments that I talked about. I have worked with a child in foster care who didn't actually, I think the family was hoping to adopt her and it didn't happen. She went back to the biological father, and it was very, very hard on everyone involved, including myself. But we did do TFCBT, and the biological father did treatment on his own related to anger. And, I was able to loop him in at the end of treatment and the trauma narrative. So during the time that she was with the foster family, they participated. They helped learn the skills to help coach her at home to use them. And they were, heard some of the narrative that she wrote. I think it is a little trickier when there's uncertainty about placements and whether, there's going to be stability. I think it's really hard on the kid, but it doesn't preclude them from participating in treatment. They just may need some additional treatment afterwards to deal with the transition.
And Dr. French, I apologize if you had mentioned this earlier. The Center for Child and Family Health that is based in Durham can be a great resource for many people. They serve the state in lots of ways, and they have great resources on their website. The other thing, and knowing that we're probably talking to a large group of people, which is if you are interested in being trained in TFCBT or interested in being trained in these other therapeutic modalities, CCFH has great trainings. And if I remember correctly, the state chips in for the cost of receiving these trainings to kind of expand the TFCBT network in the state. So if you're working with someone that you think might benefit for having TFCBT, or you yourself think you would benefit from being trained in TFCBT, I think really trying to expand that network across the state is really important.
Yeah, that's a great point, Dr. Copeland. It's the North Carolina Child Treatment Program, which is the one, it was on the slide that I mentioned. You could search by provider where they, insurance and county, the ones that are rostered in those manualized treatments. They're the same ones that offer the learning collaboratives for those evidence-based treatments.
Do you know if Medicaid will cover these treatments?
So Medicaid, actually, if you are rostered, they reimburse at a higher rate for those evidence-based treatments supported by the North Carolina Child Treatment Program. I think the billing code is not specific to the type of treatment, right? It would just be like an individual therapy code, but they will reimburse at a higher rate. There's like a modifier if you're rostered.
So yes, yeah, that they absolutely thank you, and I think that also speaks to North Carolina Medicaid's desire to have kids receiving TFCBT. So yes, they do cover the service, and for those that are doing it, they pay at a higher rate.
It looks like that was the last question that I have in the box. So thank you all so much. We appreciate your information and answering all those great questions. Thanks, everybody. We'll see you.
Thank you. Bye-bye.
Thank you, guys. We appreciate it.